Good morning, and thank you for joining the RLS Foundation's webinar titled Surgery and Hospitalization with RLS. My name is Zibby Crawford, and I'm the Membership and Marketing Coordinator at the Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Burkowski will answer as many questions as time allows at the conclusion of his presentation. The surge in the use of web-based programs during the COVID-19 health crisis has created strain on the system. If you're experiencing technical difficulty, switch to audio. Telephone number is listed on your invitation as it uses less bandwidth, and be sure that your webcam is turned off. We thank you for attending and appreciate your patience and understanding with any technical difficulties that may arise during today's webinar presentation. After the webinar, you will receive an email with a link to the recording. The webinar recording will also be made available in the member portal section of our website. If you're not a Foundation member, and if you'd like to view this and other recorded webinars, we invite you to become a member today by going to www.rls.org. As always, individuals suspecting they may have RLS should consult a qualified healthcare provider. Information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today, Dr. Andy Burkowski, is a member of the Scientific and Medical Advisory Board of the RLS Foundation. He recently started and serves patients at Relax Health, which is a direct specialty care sleep medicine clinic. Dr. Burkowski uses telemedicine to care for patients with RLS and other complex sleep disorders, providing personalized care for these conditions outside of the constraints of the insurance and hospital-based fee-for-service system. Before receiving board certification in both sleep medicine and neurology, Dr. Burkowski earned his bachelor's degree in religious studies at Stanford University. He returned to his home state of Michigan, graduating from Wayne State University School of Medicine, completing a transitional year internship at Henry Ford Hospital, and training in adult neurology at the Detroit Medical Center, Wayne State University. Dr. Burkowski then obtained fellowship training in sleep medicine at Stanford University Medical Center. He's been a faculty member at the University of Michigan in Cleveland Clinic before founding Relax Health. In addition to his role at the RLS Foundation, he is on the American Academy of Sleep Medicine Clinical Practice Guidelines Task Force for RLS, which will be publishing its comprehensive guidelines in 2023. Thank you, Dr. Burkowski, for your time and expertise today. Please begin your presentation.
Well, thank you for that introduction, Zibby. And those of you who have had to suffer through one of my previous webinars, you know that I'm a big fan of the great Sir Thomas Willis. And Sir Thomas Willis, where the name Willis-Ekbom disease, which is one of the other technical terms for restless leg syndrome, is named after this here, Sir Thomas Willis. And excuse me for my poor British accent, but sometimes a great wound or concussion of the head, especially which happens by falling headlong from a high place, brings a prejudice and weakness to the animal faculty, dulling the understanding. So this was Sir Thomas Willis back in the 17th century, and this is one of the few quotes I use. It's relatively famous, but it's not about restless leg syndrome, but it sort of encapsulates what we're going to talk about today in terms of surgery and hospitalization. There's sort of a weakness of the animal faculty, the mind, the dulling of the understanding, and that's both from a patient, like those of you who have to go for surgery and be hospitalized. You're going for surgery, you're under anesthesia, you're on medications that may impair your judgment. You're not going to be on top of things. So your understanding of what's going on is going to rely on the people around you. But at the same time, the healthcare system, the hospital, the surgeons, the staff, they may have a dulling of their understanding both of restless leg syndrome, but also the prioritization. Even if they know about restless leg syndrome, they might not be putting it first in their mind because there's all this other stuff going on. There's the surgery and the recovery and the nursing staff and the blood draws and the lab tests. So restless legs can take a back seat, and it's not going to be at the forefront of anybody's animal faculty when it comes to a hospitalization. So I think that's something to keep in mind when we talk about this. So I have no financial disclosures or conflicts of interest. Neither the RLS Foundation nor its Scientific and Medical Advisory Board have influenced or edited this webinar. So this is my own opinion, other than providing the title for me. And then some of the recommendations and conclusions are not yet evidence-based. They may reflect the opinion of me, the presenter, and it may not be consistent with some of the other RLS Foundation members. So there's not uniformity in our opinion. So just keep that in mind, that I'm not speaking on behalf of them. And then the second thing to note, as Zibby mentioned previously, that this is for informational purposes only. It does not constitute the practice of medicine. You should discuss any diagnostic or treatment decisions with your licensed medical professional. So I may say something, you don't do something that I say because I said it in this webinar, because I don't have a relationship with you and I'm not managing your case. So a quick outline of what we're going to talk about in this session. There's basically two general segments. The first is a review of important restless legs topics. So I know that we're focused more on hospitalization and surgery today, but everyone must understand the role of iron, and also to refresh the understanding of how dopamine plays a role in restless legs and how dopamine agonists are a factor, not just in your general restless leg syndrome health, but also potentially how it could be affected in a hospitalization situation. And then the bulk of the talk, we're going to focus on the aspects of restless legs that are affected in hospitalization and surgery. One of the most important things I want to emphasize is the preparation for this, particularly if it's a planned surgery or planned hospitalization. It's very important to plan this in advance, again, because the animal faculty may be compromised while you're in the hospital. Then there are specific hospital strategies that you can take as a patient, or if your loved one is a patient with restless legs in the hospital. And then we're going to talk a lot about medications, both the ones that may help restless legs in a hospitalized situation, but also the ones that are somewhat unique or maybe not so unique to hospitalization that could come up that maybe we should avoid or try to limit the use of. So let's go to the basics of restless legs and how that may play a role in hospitalization and surgery. So the state of Western medicine with restless legs is not a bright situation. So the first thing to understand is the effects of restless legs are downplayed. Restless legs does not cause sudden death. It's not a life-threatening condition. But those of you particularly who have moderate to severe restless legs, you know how disabling the condition can be to your quality of life and to how you feel. But you have to go in thinking that nurses, doctors, they just don't understand how severe the restless legs may be and what impact it might have when you're going for gallbladder surgery. Why would restless legs be important in that situation? Combined with that is a lack of awareness of the condition in two different ways. One is the lack of awareness of restless legs and the effects that it may have on you. But number two, it's the lack of awareness of the restless legs in the context of other things going on in the hospital. If you have pneumonia in the hospital, that's not going to be the first thing that they're thinking of is your restless leg syndrome. And then there's also a lack of prioritization. It's not a life-threatening condition. It's not why you're hospitalized. So therefore, it's on the lower down on the chain of priority. So that really means that you have to have self-efficacy. You have to be the one to be the champion of your own health. And if you can't do that, you need to appoint somebody who can do that. So it's important to kind of fight for yourself, particularly if this condition is going to affect you during your hospitalization, is that if it's not to the forefront of the providers or the hospital, you need to bring it to the forefront if you're going to have it under control during the hospitalization. So let's go to iron, and this is just general information, but also information that may help during hospitalization. So we know that restless leg syndrome is fundamentally it's a condition of poor iron metabolism in the brain. Most evidence points to low iron levels in the brain that cause dysfunction of the sensations of the body. And part of that low iron level or the problem of where iron goes and how it's used in the brain are fundamental to the condition. There's also a strong relationship to iron and the biological clock. Particularly, most of you who have restless legs know that your symptoms should typically occur at nighttime or be at their worst at night. And that has to do with the cycling of iron throughout the body. So any disruption to the biological clock, i.e. a hospitalization, the iron levels will fluctuate unpredictably and may cause an unpredictable fluctuation in your symptoms as well. And then there's the idea of low iron levels, not in the brain, but in actually the blood and the body itself. Those are the levels we measure with blood tests. And a hospitalization is likely to cause low iron levels. So if we don't even talk about all the other things going on, different things can cause the iron levels to become lower than they normally would be. And then therefore the iron levels in the brain can be affected. So that's an important aspect. Inflammation causes low iron levels in the body. It causes low iron levels in the brain. When there's inflammation, the body doesn't absorb iron and the brain can't get the iron that it is absorbing. And most hospitalizations, there's going to be a lot of inflammation. If you're in the hospital for an infection or surgery or some sort of injury, there's going to be a lot of inflammation, and that's going to affect iron levels. So just to review the blood test for iron, because a lot of doctors don't even understand this, that the ferritin level, there's two blood tests that are important. One is the ferritin level, and the consensus is we would like to see this at least above 75. Now, it doesn't always correlate with the brain, so somebody could have a higher ferritin level than this and still have low iron levels in the brain. But in general, you don't want to have a ferritin level below 75. And then the other test is called the transferrin saturation or iron saturation. And this is the iron divided by the total iron binding capacity. And it's a percentage. It's like how much storage space do you have and how much of it's filled up. And that should be at least 20%. The lab reference ranges may not be correct. It might say 15% is okay. Well, it's not okay for restless leg syndrome and for most other people, actually. It's just a reflection of the population that 15% is what the population has, but that's still low. So you want to get the test ideally fasting and in the morning. And in the hospital, if you get this done, most likely that'll be the case. But just think about this when you're getting it done at your home labs in routine practice, which should be done at least once or twice a year if you have restless legs. And then you want to avoid iron before the test. It might be good for your restless legs to eat steak and eggs for breakfast, but if you eat steak and eggs for breakfast and you get your iron tested, your iron levels might be falsely high, particularly the transferrin saturation. And then keep in mind that the complete blood count, which gives you your hemoglobin level, it might show that your blood counts are in normal range, but you're still low in iron, or you might actually still be anemic even though your blood counts barely are meeting the requirements. So that's why you do have to get your iron levels checked. So that's important. So just to review quickly, supplementation for a ferritin of less than 50, you generally want to use a full like 50 to 65 milligrams of iron with vitamin C at night. And then if you're between 50 and 75, you want to use less iron because it's not well absorbed at the higher dose. So you want to use less the higher you are. And again, side effects that you should know about. And then constipation is always a problem because you're putting metal down there. And if the metal's not absorbed, you're going to have harder stool. It's going to be harder to move around. So that's important. And then once you start a supplementation, it usually takes about 12 weeks to see if there's a big change. So there's a delayed effect there. Iron infusion is probably more pertinent to the hospital situation. We had a wonderful webinar last month on iron infusion, so I'd encourage you to go back and review that. But just to review some of the principles is really for most people, you can't get the ferritin above 75 without an infusion. So the way you can do that is because it bypasses the gastrointestinal system, and then it causes an instantaneous increase in your iron, so you don't have to absorb it over 12 weeks. It's absorbed right away. It's right into your blood. And there are few, if any, side effects to an iron infusion. So what are the disadvantages? insurance coverage is difficult to obtain. There's a lot of people who want an infusion or need an infusion, but there are a lot of infusion centers that aren't doing them for financial reasons, or you don't have a doctor who's comfortable ordering them, or your doctor can't even order them. They don't have access to an infusion center. And then there's a lot of myths about iron infusion reactions still. There can be all sorts of different symptoms and side effects when somebody gets an infusion, but a lot of times it's blamed on the iron and it's maybe something else going on, or there really isn't a true reaction. It's just something that happens during the course of an infusion. So it scares people away from infusions. And then doctors, as I mentioned, may be unfamiliar with iron infusion as a treatment for restless legs. But this will be an important thing that you might be able to use if you're hospitalized as to help your condition overall. So let's shift now to the role of dopamine, because this is just so important even outside of hospitalization, is understanding how dopamine affects restless legs. So iron and dopamine go kind of hand in hand. Iron is involved in dopamine transport in the brain, and the low iron levels or the poor metabolism of iron causes effects on the dopamine system. And I'll be showing you some diagrams of that shortly. And as I mentioned, we think it's mostly the dopamine transport is affected. You're not low on dopamine, but the dopamine shipments are not getting to where they need to go. And the effect of dopamine agonists, originally the drugs, dopamine agonists, which are commonly used for restless leg syndrome, were shown to be effective at first. Long-term, not so much, but at first they're very effective because they sort of bypass the defective dopamine system. But the dopamine agonists are something that we don't want to tinker with during a hospitalization. So again, the dopamine agonists, many of you or the people you know might be on these medications, including pramipexole, ropinirole, rotigotine patch. And 3 of these drugs here are three of the only 4 FDA approved drugs for restless leg syndrome. And levodopa, unfortunately, is still used for restless leg syndrome. This is really a Parkinson medication exclusively, but sometimes it's still used for restless legs, even though it causes bad side effects months after you start taking it. But some people may be on this medication as well. So I like to use my shipping port analogy, and if you've seen my webinars before, this is one that I like to use. So we've got all this blockchain, all the shipping issues, the port of Los Angeles, there's difficulty getting shipments through. Well, that's kind of like the dopamine system. The dopamine are these little packages that need to be delivered from one brain cell to another. And in the yellow, you see the stimulation of the brain cells from the dopamine as it attaches to the receptor in the shipping port. And that's kind of what gives the relief. It sort of soothes the restless leg syndrome. But in restless leg syndrome, you can see that the shipping ports are a little bit disrupted or defective. So there's actually more shipments starting to pile up. There's actually more dopamine there, but it's not getting through the ports. So it's sort of like the Los Angeles, all those cargo ships stuck in the Los Angeles harbor right now. They can't get through. And it produces less relief of those restless leg sensations. And what dopamine agonists do, they're sort of like Amazon. They come in their Amazon vans, they come with their Amazon drones, and they're starting to drop the shipments into your home. And so it sort of bypasses the system, and it does provide relief of restless legs at first, but long-term, not so much. So what happens if you're hospitalized and you're reliant on these shipments of dopamine through the dopamine agonist? Well, all of a sudden you take away the dopamine agonist and now your brain is not delivering those shipments anymore. And this is a really common problem in the hospital, is that you're on a dopamine agonist, your brain is dependent on the medications, and suddenly, boom, the medications disappear. And now you're not getting any relief of your restless legs. So that's kind of a concept you need to understand for a hospitalization, particularly if you're on dopamine agonists. So part of the public service announcement part of this lecture is to describe some of the adverse effects of dopamine agonists. The first one that people don't think of is impulse control disorders. And these are things like increase in alcohol or substance use, like smoking, gambling, shopping, compulsive eating, even doing repetitive tasks over and over again, even if the task is normal and you're doing it kind of compulsively. It's an inability to control your behavior because of the stimulation of the dopamine. And this can happen very commonly with long-term use of dopamine agonists. The other big issue, which is the main issue, is augmentation. So what is augmentation? As a review, this is an increase in your restless leg symptoms from long-term use of dopamine agonists. So the symptoms come on earlier. Instead of coming on at 10 p.m., they're coming on at 5 in the afternoon. They can spread. It's no longer restless legs, it's now restless torso and restless arms. You can develop tolerance. What is tolerance? Meaning 1 milligram used to work, now I need 2 milligrams, and then a year from now I need 3 milligrams to produce the same relief of symptoms. And when you're resting, the symptoms can come on more quickly. You can't even make it through a 15-minute car ride without having to get up and walk around. And then there could even be a paradoxical trigger, like you take the 5 p.m. dose and you actually causes the restless legs for a while before it starts to relieve the restless legs. So how does this work in this model that I built up is basically over time, the shipping ports start to close down. So Amazon's delivering the packages, but they're putting DHL and USPS out of business. And now you're not getting as much relief as you used to. And then over time, a lot of stuff closes down and you're really not getting much delivery of dopamine at all due to the augmentation. And imagine pulling back on those dopamine agonists in a hospitalized setting. You're not going to get much relief of your symptoms. So the role of dopamine agonists is quite controversial. The clinical consensus now is that these medications should not be first line, and many restless legs experts believe they should not be used except in rare circumstances. This is my belief. Again, I don't think anyone should be started on a dopamine agonist, period. And I've seen several hundred patients in my career, and I don't recall starting anybody on a dopamine agonist. So it can be done without the use of these medications. So many of you, if not the majority of you, might actually be on a dopamine agonist. So what if you're already on one? Well, you want to look for impulse control disorders, and you want to look for augmentation, which I just reviewed briefly. If you're developing these symptoms, those are not going to go away. They're going to just get worse over time. And it's time to talk to your medical professional about changing the course of treatment. But the hospitalization isn't the time to stop your dopamine agonist. And that's what I want to emphasize today, is that you do need to monitor for these things. And what you can do about it is it causes a chemical dependence. Your brain is dependent on the drug, and you will go through withdrawal as you come off the drug. So when you're hospitalized, you don't want to come off the drug cold turkey. And the good news about augmentation is if you just use the clinical guidelines as a marker, or your physician or provider uses the guidelines, much of the augmentation can be reversed long-term, but it takes a lot of work. So now that we reviewed kind of the basics of restless legs in light of this, let's move on to surgery and hospitalization in particular, and what are the unique aspects of this. So number one is the planning of the hospitalization. So obviously, you get into an accident or something and you're in the hospital, you're not going to be planning for that. But a lot of the time, you're going to be hospitalized because you're going to have a surgery or some sort of procedure, and you know it's upcoming, or you're going into the hospital for some sort of treatment. So a lot of times you can plan for that. So if you can plan, the better off you'll be. Obviously, in an emergency, you're not going to be planning for an emergency. But the key here is, because your senses will not be always within your control, you're not always going to know what's going on, you need to find an advocate. So if you're married, it could be your spouse. If you have children, it could be your children. If you have parents, it could be a parent, a sibling, or a close friend. Finding an advocate for your healthcare is very important when you're in the hospital, because the hospital is a very chaotic environment. And there's a focus so much on the urgent matters that there's the whole perspective isn't being looked at. And the people in the hospital, they don't know you very well. They're not your primary care doctor you've been seeing for 10 years. They just know you're here for gallbladder surgery, and they don't remember or even know that you have restless legs. So your advocate has to advocate for you. They have to be your voice, because it's not going to be a priority for them. I recommend contacting whoever is taking care of your restless leg syndrome, whoever's monitoring it, looking at your labs, giving you medications, to say, hey, I'm coming up on this hospitalization. Is there anything I need to do to plan for this? And they may be able to help you. So I recommend reaching out to them. And then you want to inform the surgical team and anesthesiology. So particularly if you're going for surgery, you're going to meet with the surgeon. You don't just walk in and they do surgery. There's somebody who's evaluated you prior to surgery, usually the surgical team, either the surgeon or advanced practitioners who work with the surgeon. And you might even meet with anesthesiology in advance. And you want to just bring up the restless legs as an FYI because it might not be on their radar. And then to your planning appointments for the hospitalization, you do want to bring your medication list with all your medications, but particularly the timing of your medications, because as I mentioned in the initial slides, this is a biological clock problem. You can't just take your medications. They have to be given to you at the correct time for them to work. And this is more important than even some other conditions which are not based on timing. So what to bring to the hospital? So you've gotten through those initial visits, and now it's time to bring with you, you want to bring, again, your medication list along with the timing. And then we generally recommend actually bringing your medications themselves, preferably in the original bottle. So let's say you're on gabapentin and the hospital doesn't have gabapentin on formulary. They might have to give you Lyrica or pregabalin. You don't really want to switch around your medications. It's not like certain other drugs where they're really interchangeable. A lot of these medications are not equivalent to each other. And if the hospital can't get the medication or they don't have the medication, you could insist that you take your home medication. And by bringing the bottle, the pharmacy can look at it and verify it. It's just easier to identify what dose you're on and how much you're taking. And then it'll help the pharmacy to identify the pills. I think they have to review these pills before you can take them. And then the nurse will administer your own medications to you. Then you want to keep a list of your own restless legs triggers. So some people, it's red wine. Well, the red wine, they're probably not going to give you red wine in the hospital, hopefully, but it might be some medications that trigger it, or some other different things in your diet. So maybe to avoid those things in the hospital food. So just bring a list of your triggers so you could kind of avoid those, because they're not going to know what those are unless you bring them on a list. And then it might be good to have the name and number of your RLS provider. So if you get into any issues with having trouble controlling your restless legs, maybe the resident or the physician in the hospital or your nurse can call your restless legs physician and just discuss some tips as to what they can do to help you relieve your symptoms. And then an important thing is the RLS Foundation has put out a series of publications that might be helpful for you to just kind of print out and bring with you. So this is one of the advantages of becoming a member of the RLS Foundation, is having access to these documents. So on your left, the RLS Medical Bulletin. This I helped with the editing of this. It's just been updated this past year, I think in 2021. And it has the breakdown of everything a physician would need to know about restless legs. And you could kind of just bring in this pamphlet, and if there's a debate over some issue, whether it's iron or medication, you could give this to your nurse, you could give this to your whatever doctor is caring for you in the hospital. And then on the other side, the right side here, is the special considerations for the surgical team. So this is a couple-page document which just summarizes like what a surgeon or the anesthesiologist might need to look out for. So these are potentially helpful to bring to any hospitalization. The other thing that you may want to bring is sort of a medical alert card. This is the one that we have at the RLS Foundation. On the right, it has all of the medications that you should or should not use, which we're going to go over soon. But on the left side, it just makes people aware of restless legs, because people, it's not on their radar in the hospital. And if you're in surgery and your legs are moving, now they know why. You've brought this to their attention that, hey, maybe your legs will start moving during surgery, and you're not going to be talking about it, but you've brought this to their attention. So having this in your wallet or purse might be a good idea just in general, so people have quick information. So that's kind of on your way to or during your approach to entering into the hospital. Now, once you are in the hospital, then there are other things you need to know about this situation. So let's review some of the activities that affect restless legs. This is sort of some of the basics of restless legs, but let's look at what you can control when you're in the hospital. So, what could make restless legs worse? Sitting, lying down, and inactivity. So if you had surgery, you're going to be sitting, lying down, and very inactive for a long time. So being in a hospital bed all day is probably not great for restless leg syndrome. And a lot of that you're not going to be able to control. You may not want to start taking up excessive coffee or caffeine intake. Hopefully, if you're still using nicotine in some form, you can cut back on that or quit using that or cut down. They may give you a nicotine patch in the hospital, but just be aware that those are the triggers to try to avoid. And what may improve. So this is what you can control to help with the restless legs. I can't emphasize enough how important it is, even if you had leg surgery, to get yourself on your feet and moving around. The people who are patrolling the hospital ward, those are the people, they look like they're up and down with their IV poles. That's what you want to be. You want to be in that line of people navigating the hospital in their hospital gown with their IV pole. You want to walk as much as you can, given the circumstances. Now, you're not always going to be able to even get out of bed, but if you can, you have to make a very strong point. This goes for all patients, but particularly if you have restless legs. Leg massage is something that for a lot of individuals, it does help. And in the hospital, they have these sequential compression devices. These are they're attached to a little motor and they Velcro onto your calves and legs. And a lot of people with restless legs find these to be very soothing, and they give different levels of compression. The purpose is to avoid, move the blood around so blood clots don't develop in the legs. But some people find these to provide some relief for their restless legs by that stimulation of the legs and the muscles. So you could ask for them even if they weren't planning to give you them. That might be something you'll have access to in the hospital. You can't really often take baths in the hospital, but a warm shower may help stimulate the legs. So that could be an option if you're able to move around enough to take a shower. And then stretching exercises, things that you've learned that help at home, you may want to do in the hospital. But really the key is getting out of that bed as much as possible and walking around. So medication administration. So these medications, if you're on a medication for restless legs and you're on a first line medication, it could be one of these three. Horizon is the fourth aforementioned FDA approved drug for restless legs, and then pregabalin or Lyrica or gabapentin. These are the most common first line drugs for restless legs. You want to make sure that you're being put on the drugs and you're being put on them at the right time. If your restless legs happens at 10 p.m. and they say, oh, gabapentin 300 milligrams once a day, and then the nurse, the medical assistant brings your gabapentin at 9 a.m., the gabapentin is gone by the night. So if they don't have the time right of your gabapentin, if they give it to you in the middle of the night, they give it to you in the morning, that may not help your condition. So you want to make sure they give it to you preferably at your home dose, if not maybe a little bit higher. And you want to have it done at the right time that would actually help to prevent your restless leg symptoms. Dopamine agonists, as I mentioned, I don't advocate for people starting on them. If you're already on them, you should not suddenly stop taking them when you're hospitalized. You will go through severe withdrawal. That dopamine system will be completely disrupted if they kind of just cut off your pramipexole all of a sudden. So if you're on a dopamine agonist, whether you should be long-term or not is a separate issue, but if you're going for surgery and hospitalized, you should try as best you can to get your staff, your hospital staff, to give you these medications at the same time every day at the correct dose and not switch between one and another. That's why it would be good to kind of bring in your medications to the hospital so you're actually taking the right dose of the right drug. And then opioids. Many of you may be on opioid medications, and we'll talk a little bit more about that, but these can work in your favor. But ideally, if anesthesiology does not need to make any major changes, if you're on a long-acting opioid like methadone or buprenorphine, for example, it would be best to just stay on the dose through the hospitalization. Now, sometimes they're going to have you go off of it, and that's going to be a more complex situation. But most of the time, they'll let you stay on these medications. And then there's oxycodone, hydrocodone. These are the short-acting agents, and usually those can be part of a surgery recovery. These may not need to be modified quite as much because they only last for 3 to 5 hours. But make sure you still get them. There's going to be a lot of apprehensiveness about giving you the medications that you're on, but you want to really, you just can't substitute for these medications as much as you can. You want to avoid that. So then there are the drugs, not that you've been taking, but the ones that are given in the hospital. And the biggest issue with surgery and in the hospitalized setting are anti-nausea medications, antiemetics. So what you want to do is avoid dopamine blockers like Reglan, Phenergan, and Compazine. These are the three. These are dopamine antagonists, dopamine blockers. So if you already have a problem with your dopamine system and then you block the dopamine system, that doesn't sound like a great idea. So these drugs are probably not great for your restless leg syndrome. So just make your anesthesiology team, your nursing staff aware that if possible, if you have nausea, to avoid these. Sometimes these are part of pre-medication for, say, chemotherapy, pre-medication for surgery. And if they can use a different medication, that might be better. So the ones that, in general, not everything's great, but Zofran, Kytril, and Dansitron, Granisetron, these tend to be more affect the serotonin system. And so these are a little more neutral towards restless legs, so they may have some mild effect on restless legs. Another one to think about is lorazepam or Ativan. It's not considered an anti-nausea medication. It has a lot of other properties, but it actually works really well for nausea, and it's given to a lot of patients, even patients getting chemotherapy. But lorazepam could actually relax the central nervous system, and it may help with restless leg syndrome. So that's one to keep in mind as well. So then antihistamine. So again, diphenhydramine, doxylamine, most people aren't taking these for allergies anymore. They're taking it for sleep or to make themselves drowsy, or if they have a cold. But these tend to be restless legs triggers. This is a type of antihistamine. The newer ones, they don't get into the brain as much. The newer ones are your Allegras, your Claritins, your Zyrtec. They don't penetrate into the brain. They don't make you as drowsy, but they also don't trigger the restless legs to anywhere near this extent. So if you need allergy medications for medications or just for allergies in the hospital, you want to consider the newer generation antihistamines. And then moving on to sleep and sleeping pills. So sleep is extremely important for restless leg syndrome, and your sleep in the hospital is very disrupted. And I'm not talking about just them coming in for putting an IV in or doing a blood draw. I'm talking about you will be constantly disrupted in a hospital. Sleep does not have any priority in a hospital system. The custodial staff might wander into your room at 1 a.m. and empty your trash. Why do they need to do that at 1 a.m.? Well, maybe they don't have anything else they need to do at that time, so they're assigned to emptying the trash. You could put a sign on the door to minimize disruptions like that, or have them come in when you're awake. The blood draw team is going to come in at 4 a.m. Why do they come at 4 a.m.? Because the residents or the doctors want their labs at 6 when they're going on their pre-rounds to see all their patients. And so they might come in 4 hours later and wake you up. So the hospital environment is a constant state of disruption. The nurse might come in every 2 hours to check your vitals and wake you up. So it's understood that there's going to be a severe degree of disruption to your sleep. Disrupting your sleep is going to disrupt your biological clock. It's going to disrupt your restless legs. We know this, but try to control what you can, and what you can't control, you can't control. Another key is to maintain a schedule. So how do you maintain a schedule when you're on the hospital schedule? Well, try to keep your sleep and wake schedule intact. So if you go to bed at 11 and wake up at 7, try to do that. I know the doctor might come in at 6 o'clock, but try to keep it 11 to 7. You don't want to suddenly start sleeping all afternoon if you can avoid it. You want to sleep at night and you want to be awake during the day. If you're really sleep deprived from the disruptions, you could take a 90-minute nap, but don't sleep for 5 hours throughout the day, because that's going to throw off your biological clock. It's going to throw off your sleep, and it might worsen your restless legs. And then be aware of the environment. So that goes hand in hand with it's 1 p.m. in the afternoon. Don't have everything dark. Open the windows if you have windows, and turn the lights on. And when it's midnight, it should be dark, just like it is outside. So if your neighbor, if you unfortunately are in a shared room, have your neighbor turn down the TV and hopefully keep things quiet and keep the lights off. Hospitals are starting to do a better job with this, but try to control what you can, because this is not on the top of their radar. So these are things you or your advocate could look into. These are very simple things that can help with your sleep quality and your biological clock. And then bring a CPAP as well. So if you have obstructive sleep apnea, which is a known trigger of restless legs, you don't want to compound things by not bringing your machine, because the CPAP's not going to be on the nurse's radar either. and helping your breathing, particularly if you're on a lot of medications, is going to help your sleep quality. And then avoid medications for sleep. Your body knows when it's stressed, and your body also knows when it needs to sleep. And you might be somebody who gets a lot of sleep in the hospital because you're just knocked out from all the drugs, or you might be disrupted by all the commotion and you might not sleep very well. But do the best you can and realize that getting medications for sleep may not be the best outcome for this. It might be better just not to sleep that well than to be on the medications. Now, if you need to resort to medications, again, avoid the antihistamines that are going to be the first ones that are going to give you for sleep, because these are the least, in terms of, controlled substances or dangerous drugs, are going to give you the over-the-counter stuff first. And then you want to avoid antidepressants. Trazodone is an antidepressant that can trigger restless legs. It's commonly used in the hospital because, again, it's not a controlled substance. Doxepin is another one that can be sometimes used in a hospital setting. So try to avoid those. You might not fall asleep, and then you might have worsened restless legs because of these drugs. And then antipsychotics, Seroquel, Zyprexa, or olanzapine. Sometimes that's used for nausea. Sometimes it's used for sleep or other things. So try to avoid these dopamine blocking antipsychotic medications for sleep. And then the ones you do want to consider are the ones that nobody wants to prescribe you. So your traditional sleeping pills, Ambien, Restoril. Again, I mentioned Ativan for nausea, Ativan for sleep. I'm not advocating these for long-term use, but for a couple nights in the hospital, I would prefer a patient with restless legs be on Ambien than I would on Trazodone or Benadryl. So you could emphasize that these are the ones that are more neutral or positive towards restless leg syndrome. So the next point is I gave a big spiel about the importance of iron in the condition. So the people who need to look out for this, particularly those of you who are low in iron in your body to begin with before, for example, a surgery, you really want to pay attention for this. Blood loss from surgery is just a common cause of restless leg syndrome becoming worse both during hospitalization and then after surgery. If you're even small procedures can lose enough blood, you lose the blood, then your body needs to remake those blood cells. And iron is like the concrete to build these blood cells back up, and it's going to suck the iron away from your brain and put it towards making blood cells. Then there's the case of inflammation and poor nutrition. So the hospital food is really devoid in nutrition. It's tends to be kind of low fat, low in iron, not a lot of steak and red meat being provided, like sources of good nutrition, or you might just not have an appetite or be eating much of anything at all. And so you're not getting iron in, and then you have an infection, you're on antibiotics, you just had surgery, there's inflammation, so you're not going to absorb iron. So this is the opportunity to ask your doctor, it's off the radar for them, but ask for iron infusion during your hospitalization, particularly if you started with low iron, because it might be easier to get it in the hospital than you might have a hard time getting it for 6 to 8 weeks after you're hospitalized. They actually do have access to iron infusion in the hospital. The one I would recommend that's maybe they might have it in the hospital is iron dextran or Infed. This is a stronger formulation of iron. You could give very high doses in one infusion. The ones you're typically going to get are iron sucrose or Benifer or ferric gluconate or ferlecet. These two we don't recommend in general for iron because they have the type of iron that can be given only in low doses, and they don't penetrate into the brain as well as some of the stronger formulations like Infed. But it's expensive. The hospital doesn't make extra money by giving you the iron, so they're going to want to use the cheapest, lowest dose stuff. But that's still better than not getting any iron, in my view. So if they can give you, you're hospitalized for 5 days, and they can give you 3 doses of ferric gluconate, 125 milligrams, you might get 375 into your system in a 5-day hospital admission. That's better than 0. So really ask about that, and they may just do it. They may not have any issue. You already have IVs in your system. They don't have to put a new IV, and they could just give it to you at some point during the day. And that may help both in the short term, but also as you recover from surgery. So we haven't seen Sir Thomas Willis recently. So let me talk, let me convey what he says about opiates. So he says, "Sometime since I was advised with for a lady of quality who in the night was hindered from sleep, by reason of these spasmodic effects which came upon her only twice per week, leaving wholly the opium, was able to sleep indifferently well. So opioid medications, they've been used since the 17th century for restless leg syndrome. In a hospital setting, they are a friend and not a foe. So in my first line there, the effects of the opioid crisis are being felt by the restless legs community. So there are over 100,000 deaths per year from opioid overdoses in our country. And this is a huge problem. There's a war on drugs. And as a restless legs patient, you're being caught in that. As a surgical patient, you're caught in that because they're not being used as much for surgery and pain anymore because people are so afraid of them. The medical providers are now afraid of these drugs. The pendulum has swung in the wrong direction, too far in the wrong direction. And so one of the things you could have in your favor, particularly if you're going for surgery or they're treating you for pain anyway, is using the opioids both for the pain and for the restless legs. So this is a convenient situation. Now they're going to be very hesitant to do this if they're not already giving it to you. Three of the most common things are oxycodone, which might be in the form of Percocet, which has a Tylenol or acetaminophen in it, or hydrocodone, which is also with Tylenol, also called Norco. Those two are short-acting opioids. Those can really help with restless leg syndrome. That doesn't mean you need to take them. That's not your new treatment, but it could be your new treatment for the hospital setting or for the days following your hospitalization. If you have one of these pumps or they give you, you're not swallowing anything, they can give you IV morphine and it could provide a couple of hours of relief of your restless legs. So you can discuss this with your providers and that, the opioids have a dual benefit. They help with the pain from the surgery or whatever is causing your illness that you need to be hospitalized. And they can also affect the restless legs in a positive way. And another publication, this is not from the Restless Leg Syndrome Foundation, but this is from the Mayo Clinic proceedings, I believe from 2017. It was sponsored by the Restless Legs Foundation Advisory Board, but it's the appropriate use of opioids. So it's not that you're some random patient who's asking for hydrocodone. You could actually bring a publication that shows that this is how we use opioids. This is a legitimate treatment. Heck, Sir Thomas Willis used it 400 years ago for restless legs. So this might be another thing that you could print out and bring to your doctors as well, either before or during your hospitalization to have on hand. So that's sort of one of the advantages of a surgery is that they may be more willing to give these opioids where 3 months later, they're not going to want to give you any opioids for restless legs. But in the hospitalized situation, you could use the opioids to your advantage. So what happens when you come home? What do you want to do? You really want to get back on your home medications at the previous doses before you were hospitalized as soon as possible. So that would be ideal. And then you want to push your activity in someone with restless legs, or if you have a loved one with restless legs, the more active you are, even if it's a hip surgery, you want to get your hip moving, you want to get those legs moving. That's going to be important. And then maintain your schedule, because some people can come back from the hospital, they're sleep deprived from the disruption, lots of inflammation, just been treated with all these medications, but you still want to keep some semblance of a sleep and wake schedule, because if you disrupt, you start sleeping all day long, that's going to throw off your restless legs potentially for several days to weeks. So you want to kind of get back onto a routine. You might need more sleep, but you want to try to keep your bedtime and wake time as consistent as possible, which will help with the restless legs. And then for those of you who aren't on opioids long-term for restless legs, you want to slowly taper the opioids and be back on relying on your regular medications. Now, if you're on opioids at home, you want to kind of get back to the type of opioid or the dose of it, but sometimes slowly tapering the opioids will lead for a soft landing of your restless leg syndrome. So you don't want to kind of, the pain gets better, but then you suddenly cut off your opioids. Your pain might be okay, but then your restless legs might bother you for a few more days as your body is recovering. So you can kind of make a slow taper of the opioids if they are given to you upon discharge. And then for most people, even if you're not hospitalized for surgery and you're not going to lose a lot of blood, you probably want to recheck your iron levels 4 to 6 weeks later. Like I said, infection, inflammation, all of the things that go on in the hospital, that can really affect your body's storage of iron. And that could create a deficiency in iron where maybe you weren't deficient before, but now you're deficient after the hospitalization. So probably want to arrange for that. maybe 4 to 6 weeks later once your iron levels stabilize. And then I would recommend setting up an appointment with your restless legs provider maybe a few weeks after your surgery or your hospitalization, just to make sure you're on the right track, particularly if the condition gets thrown off by the hospitalization. So those are the things you want to do at home, but eventually you'll kind of get back to your usual self. So that's the good news, but these are what you can do in the immediate days following from surgery. So I mentioned a few publications. This is a screen capture from the RLS Foundation website. So those of you who are members can go to the member portal, and if you go under publications, if you scroll down, there is information on your left bottom is surgery and restless legs for the patient, and then on the right is hospitalization checklists for the patient with RLS. And so a lot of the information I went over today are also found in these documents. They're 1 or 2 pages long, so you're not going to have to kill several trees to print these out. But these are things that you may want to read and look at prior to any surgery or hospitalization. So let me review the points to remember is that restless leg syndrome is a condition about iron, and hospitalization is a state where your iron is going to be disrupted potentially. So use that, monitor for it, maybe get some iron infusions while in the hospital. Limit changes as much as possible when you're hospitalized. Try not changing your medications. Try not to change your routines as much as possible. The third thing is opioids are not necessarily a foe. They might be your ally in a hospital situation. So you can use those to your advantage to provide coverage. If your iron and other things are affecting your restless legs, the opioids might be able to cover up some of those extra symptoms you might otherwise have. And then again, the preparation, if you can prepare for the hospitalization or surgery, having an advocate, and then all of the resources we discussed today are going to be very helpful. So again, I have started a clinic called Relax Health. So for those of you in Michigan and Ohio, or actually nearby Michigan and Ohio, I'm happy to provide care for you. The clinic is dedicated to restless legs. That's why we're called Restless Legs and Advanced Consultants for Sleep. We put restless legs first in the name, in the acronym. So we really focus on that. I have a blog that's very heavy on restless legs topics. So this is my information. And those of you who want to reach out to me by email or go to my website. And then I'll open it up. I think we have 7 or 8 minutes left for questions.
Well, I think you've answered most of the questions, but maybe we can review a little bit. My restless leg syndromes emerged after a total knee arthroplasty. Is there any reason to think the two events have a causal relationship?
Right, so that's an interesting thing that it does happen sometimes. Sometimes there's surgery to either the legs or the hips where you feel the sensations in those areas. And there's probably 2 areas we don't know for sure, but one area is, again, everything around having surgery, losing blood. So there's some degree of inflammation, some of the effects of the surgical procedure themselves. So that's what we covered in the lecture today. And then there's the second aspect is that the nerves are like a computer system. They overlap in the legs. They go up the spinal cord into the brain. So even though restless leg syndrome is maybe 90% a brain condition, it's still the same area of the body that is affected, that if you have a knee surgery, you're going to have pain or disruption to the nerves of the knee, which go back to the brain, and they may overlap with the restless leg center. So some of these conditions that affect the nerves in the legs or the spinal cord may also trigger the restless legs. So it's probably not a coincidence in that case.
How do I avoid RLS getting worse when I quit taking opioid pain meds after surgery?
Exactly. So that question, I tried to answer that a little bit in the presentation, but you probably want to take opioids, even though if your pain goes away, maybe you don't cut it off on day 1, you kind of make a gradual taper. And if they give you 30 tablets, you kind of taper it down over a few days. So it gives you a soft landing. But then it'll depend on the circumstance. You lose a lot of iron and there's a lot of inflammation, or you're coming off of an infection. Your restless legs itself might be worse. And that's where you may want to reach out to your doctor, say, hey, I'm about to come off opioids, but my restless leg seems to be worse than before I was hospitalized. Can I make adjustments to my other treatment, whether it's an iron infusion, whether it's, if you're on gabapentin, is it an increased dose for a few weeks? So that's where you want to work with your restless legs provider and making adjustments to the opioids, and also making it clear that the people prescribing the opioids that you might need a kind of a soft landing when it comes to these opioid medications, because they're providing a dual benefit, not just to the pain, but also to the restless legs.
What is the best way to guarantee you won't be left unmedicated if you become unable to advocate for yourself?
Yeah, that's a big problem. If you're hospitalized, you're in a coma, you're impaired, you need an advocate, because again, this is not on the radar. So having someone there to advocate for you, a relative, a spouse, a family member, explaining restless legs to them and having them talk about that on your behalf when you might not be able to talk on your behalf because you're impaired, that's important. So having a companion, and that's probably true of anybody who's hospitalized, but making sure that your companion at the hospital is there. Now that COVID restrictions are lessened, there could be more visitors. So having somebody there who knows the condition and knows how to help you in that is very important in terms of the planning process.
I'm single and want a qualified person to advocate while hospitalized. Where should I look to find or hire a patient advocate?
So that's a difficult question because if you don't have somebody you already know, you may want to contact the hospital administration, because hospitals have what are called case managers or care managers. Sometimes insurance provides these, but a lot of times the hospitals themselves may have somebody who can act as a spouse or act as a brother or sister or sibling, and you might be able to educate them on that, and they could advocate for you. They could be present from time to time in your room to advocate for you. So I would, particularly if you're planning the hospitalization or surgery, is to contact some of the administration, the patient advocate groups in the hospital. They all have them. They're under different names, but they may be able to provide you with someone who can advocate for you. And you want to make them clear it's not just about advocating for your surgical recovery. It's actually about the restless legs is important to you, and you need that monitored by them.
I take an opioid for my RLS. For a colonoscopy, the scheduling team wanted to have anesthesia instead of sedation. Why is this?
That's a very good question. Most of the time, it really depends on the level of opioid, if it's a long acting or short acting, and how strong the medication is. The anesthesiologist is worried that you could become a little bit desensitized to the effects of opioids. So when they try to put you under or they give you sedation, your brain is not as sedated by them because they're used to being exposed to opioids. That's probably the best explanation. That you'd probably have to ask an anesthesiology specialist that, which I'm not. But I think that's their thinking, is that we need to put you under anesthesia, because if we just do what is called conscious sedation, where they give you a little bit of medication to kind of make you less conscious but still awake, that it's not going to be strong enough because you're already on this other opioid. So that might be useful, because you really don't want to be not sedated if you're having some of these procedures done, and it might be better to err on the side of having more anesthesia in that case.
How does inactivity versus being more active affect RLS symptoms?
So that's a big problem in the hospitalized situation, is because the hospital staff wants you, they prefer you're not up and walking around sometimes. The surgeons want you walking around, but sometimes the nurses don't want you to trip and fall or pass out, get caught in your IV pole, and because falls are a big quality measure within the hospital. So anytime there's a patient fall, it's a big ding against the hospital. And so they sometimes don't want you walking around or up on your feet, but these are really important things to be aggressive about. As much as you can control is to be active and on your feet, whether you have restless legs or not. Your body can become very debilitated lying in a bed all day, especially for several days in the hospital. And it's very important to have movement, both for restless legs and for every other health condition that's involved.
How can you warn nurses and caregivers if you're having foot or ankle surgery and therefore unable to move around?
So that's exactly part of the planning process. If it's not an emergency foot or ankle surgery, you know that that limb might be need rehabilitation, or it might be somewhat compromised, but you're going to have physical therapy. So to be very aggressive about the physical therapy, being aggressive about moving it as much as they will have you. If you're in traction where it's immobilized, it's very hard to do that. But that's where you can compensate. If there's pain and they're giving you opioids, the opioids will hopefully relieve the symptoms. If you have a way to plan this, you can work with either your surgical team or your restless legs provider to maybe give some compensation. Maybe you get an iron infusion a few weeks before the surgery, they'll give you a big boost. Maybe you adjust your doses up temporarily a little higher so it can compensate for the lack of mobility. But that's part of that planning process. And it is difficult because if you can't move your leg, you might not be able to move it. So that's where these external devices may be helpful, the sequential compression devices, but then also some of the other medications. And moving around your other leg or getting your body moving might help with some of that feedback to relieve some of the sensations as well.
Well, that's our time, and this has been really, really helpful. I can't tell you how many people we get requests for information about hospitalization. So we'll definitely be making this available to all of our members. Thank you so much, Dr. Burkowski, and thanks everyone for attending.